Hello and welcome to Adam Ruins Everything, the podcast. I am your host, Adam Conover. I'm also the host of Adam Ruins Everything, the TV show, which, quick reminder, airs every Tuesday night at 10 p.m. Eastern, 9 p.m. Central on True TV. We got all new episodes for you for the rest of the year. You can also find clips and full episodes at truetv.com/Adam Ruins Everything and the Watch True TV app. Now, on this podcast, I talk to researchers, academics, and experts from around the world of human knowledge about the work they do and why it is so fascinating and, dare I say, important. Today is a special one. We actually have two guests on today. They will be talking to me in unison. The first is Dr. Joann Elmore, who appeared on the TV episode Adam Ruins Hospitals, where she talked to us about mammograms. Now, the thing about mammograms is we all have sort of been told that mammograms are this no-brainer. You should go in as early as possible, as often as possible, because that's the way to stop breast cancer. And what recent research seems to have shown is that mammograms are a lot more complex of a testing mechanism than we think. There are actually a lot of downsides, and they're not quite as beneficial as we had hoped. Now, that doesn't mean that they don't save lives. They do, but the issue is very complex, and these are things that you should know before you go in and get one. That's what Joann came on the TV show to talk about, and that's what she's coming on this podcast to tell us about in more detail. Dr. Elmore is a professor of medicine and an adjunct professor of epidemiology at the University of Washington and an affiliate investigator with the Fred Hutchinson Cancer Research Center and the Group Health Research Institute. And along with her, she has brought Dr. Janie Lee onto the show. Janie is an associate professor of radiology and the section chief of breast imaging at the University of Washington, and it is an actual radiologist. So we not only have Dr. Joann Elmore's perspective, we have the perspective of an honest-to-goodness radiologist in the person of Dr. Janie Lee. I am so excited to have both Joann and Janie join us today from Seattle. So let's get to the interview and start talking mammograms. Well, Joann and Janie, thank you so much for taking the time to come on the show.
Our pleasure. Yes.
So I want to know if you could just start by introducing yourselves and to our audience and say what you do and the distinction between your two professions.
Perfect. Well, this is Joann Elmore. I'm an internist. I'm a physician. I see patients in an adult medicine clinic, take care of everything from hypertension to diabetes to pap smears and talking with women about getting screening mammograms. And I'm the one that fills out all the referral forms to send them to get the screening mammogram.
Got it. And Janie?
My name is Janie Lee, and I am a breast imaging radiologist at the University of Washington. And so we have our clinic where we use all sorts of diagnostic tests to look for breast cancer. We use mammography, ultrasound, and MRI, magnetic resonance imaging. And if anything needs to be biopsied, we perform biopsies. And if breast cancer is diagnosed, we work with other doctors, surgeons and oncologists and radiation oncologists to use imaging to guide treatment.
I'd love to just quickly recap sort of the message that you gave us on the televised segment of the show, which is that people have been sort of told over the last couple decades that, hey, mammograms are super essential. All women should get mammograms as often as possible, as early as possible, et cetera, and that it's this sort of like very, very key test for stopping breast cancer early. And you've sort of found through your research and through your experience as a doctor that it's more complex than that. In what way?
Boy, where to start with that?
I know. I like to make the topic as big as possible early on. So start wherever you seem fitting to you.
Okay. Let me start with the big picture to say that mammography can and does save lives, and it is a very important medical test. Unfortunately for us, we're finding that the benefits are less than we had hoped for. And there actually are potential harms. Anything that we do in medicine and in life, there are potential harms. And because of this, it's a fine balance. And I want my patients to be informed and to make a decision that's right for them. And over the years, we have realized that we shouldn't perhaps start at such a young age 35. That's when they used to recommend that it start, and now they're saying perhaps in the 40s, and now some groups are saying in the 50s. And in other countries, they're recommending screening in the 50s. We used to say every year, and now they're saying perhaps every 2 years in some populations. And so it's a complicated topic. And that's kind of my big picture summary. We can delve into some of the details that I'm sure you have questions about.
Sure. Well, yeah, let's talk about, I mean, most people think that, hey, if I take a test, it's just a screening. There's no harm in that. If, there's something there I want to know. What are the potential harms of just getting a screening exam?
Well, let's start with the fact that we're talking about screening and not a diagnostic exam, because with screening exams, patients are healthy, they don't have any abnormalities, and we're looking for things that we could detect early and try to help patients. And
Right.
There are diagnostic mammograms that we use very frequently in clinical practice, and that's when a patient comes to me and she has a breast lump and I order a diagnostic mammogram. So those are two different types of exams.
Right. The screening ones are the ones where it's where you go in just sort of preventatively. You have you've detected no abnormalities yourself. You feel fine, and you go and you get it just to be sure. And the diagnostic mammogram is the one where it says, okay, we've already found something. There's already some evidence of some abnormality, and we're going to recommend that you do this. And when you talk about the potential benefits and harms, you're talking specifically about the screening type, right?
Yes, and we do lots of screening in medicine. We do Pap smear test for cervical cancer screening. We test for cholesterol. We test blood pressure. We do a lot of screening.
Got it. And so what can be the harms of getting those screening mammograms too early or too often?
Well, maybe we should step back and start with what's it like to get a mammogram.
Sure.
Women come in and you have to disrobe, take off your bra and your shirt, and you have to lift up one breast, put it on top of a hard plate, and then you take a second hard plate and you come down from the top and squish the breast together. And I can tell you that you're not here in the studio with me, but Janie, our radiologist, is smiling at me. But, you basically do have to apply compression to the breast. It can be uncomfortable, but it's really transient, and most women, they're willing to accept this. It's important because you want to not let the breast wiggle around a lot. You want to sort of reduce the motion artifact. You want to reduce the amount of radiation that you have to use on the test. And so it is important. But, one of the potential harms is that it can be uncomfortable. You can imagine someone taking your right testicle, lifting it up, putting it on a hard plate, and squishing it with a second plate so that it won't move while they shoot the X-rays.
Yeah, I'm imagining that. Yeah.
Okay, good.
There is a reason
okay,
for
so
it.
I think I've got some picture of it, and yeah, so that's off the bat something that I don't want to do unless I have to. But if it was going to be beneficial for my health, then I would do it.
Well,
You're right.
And I do want to explain just a little bit. We do apply compression. We do it for a good reason. One of the things that it does is it minimizes the radiation that we need to take a good picture. And to explain what a routine mammogram is for those who haven't experienced one, we take two views of each breast, and one view kind of essentially using the nipple as a marker lets us see kind of the top and the bottom of the breast, and then the other view lets us kind of see side to side, right? So closer to the middle, or farther away, and that's sort of when we see something, it helps us say, well, is it something we see on two views, which makes it more likely to be real? And if we do see something, where is it? Because now we can say, is it in the upper breast or the lower breast? Is it in towards the middle, or in the inner or the outer? And so that helps us find something when it needs to be brought back for further evaluation.
Now, Janie mentioned radiation. And that's something we didn't really talk about on the show. And patients always ask me about. I'm an internist. I see patients in the clinic. And I'm wondering, Janie, what you have to say to patients about the amount of radiation exposure they're getting.
Sure. The amount of radiation that we use to do a mammogram is, we try and use the lowest amount to get a good image. And a mammogram, actually, the exposures are relatively low compared to other diagnostic tests like a CAT scan, a CT scan. And we also have to understand that there's radiation all around us. So there's sort of background radiation associated with where you live. So for instance, there's more radiation if you live at a higher altitude or a lower altitude. If you take a plane flight, a cross-country plane flight is associated with radiation as well. So the amount that we use medically is usually there's a good reason for it, and we take precautions to use as little of it as possible.
But is there any risk associated with that radiation overall, or?
That's a good question. It's something that is hypothetical. We do think and acknowledge and know that there is a risk from radiation exposure, but it's hard for us to estimate. We know from things like the Hiroshima bomb, people that lived near the epicenter of that, they had a much higher rate of subsequent cancers. We know that when women are younger, starting mammography screening, that they're at higher risk. And so how many cancers we're actually causing, we can't tell you exact numbers. We can't give good estimates. We think it's a low amount, but it's a potential risk.
Right. Is it? So it's sort of this nebulous issue where, even when you go to the airport and you get scanned by one of those scanning machines, people worry about the risk of radiation, and we're told that it's a very low amount, and that we should be safe, and you can say, oh, it's similar to the amount of radiation you get in other XYZ normal scenario, but there is still some amount of radiation passing through you as a result of the
Right.
test.
What does a very low amount mean? Exactly.
Right. Well, so let's move on to the issue of once, you've actually found something via the mammogram and how variable that can be.
Well, a mammogram is a screening test, and they look for abnormalities, and if they find something, then they will obtain additional x-rays. They may, and usually if they find any abnormalities, it's easily taken care of with just additional mammogram x-rays, maybe an ultrasound. It is much less likely that women have to go on to have a breast biopsy or any tissue taking. But what surprises people is how common getting this call back from the mammography facility is in the United States. And I thought you did a great job in your TV show explaining that it's about 1 out of 10 women that goes to get a mammogram, a screening mammogram. She'll get called back for additional testing, and she'll either get a letter in the mail or a telephone call. And the mammography facilities do a great job, and they're very sensitive and try to sort of help women through this. But I have a lot of women calling me very anxious about this. Some women, it doesn't sit very well to hear, dear Mrs. Smith, don't worry, but you might have breast cancer. We need you to have you come back for additional testing. And I think that the fact that you brought up how common it is will help people so that when they do go in to have a screening mammogram and they get this call or letter, they will realize, okay, that's just part of the experience.
And there are things that we can do that we know we can do to minimize it. So one thing we can do to prepare patients is to say, the first time you have a mammogram, it's much more likely that you might be asked to come back for another exam. But once you've come back a couple of times, and we can say, she's looked like that. She looked like that 2 years ago. So she hasn't changed. And so that's much less likely to be a breast cancer that we're worried about. And so we won't ask her to come back for that. And so one is sort of to kind of know that your chances are higher on your first mammogram than when you come back later. And that if you go to a new facility, if you bring your old mammograms with you, that will also help the radiologists who are looking at the images and reduce the chance of being asked to come back.
Now, you mentioned, Janie, to have women bring their old mammograms with them. I think that's kind of hard for women to know how to do. I often tell my patients, try to go to the same facility, because then they'll have your old films for comparison, and they'll be able to look at that little abnormality and know that, gee, it's been there for the last decade, and they'll be less likely to call you back.
That's one of the great things, actually, about digital imaging now is actually when women come into our clinic, we ask them for permission to obtain their prior mammograms. If they've gone somewhere else, if they can remember where they had it, we can always call and say, she's given us permission, and would you kind of beam them over to us? And that, so that's much easier to do now than when we used to use films, like actual films that you could hold in your hand.
Right. It's funny because, that would never even occur to me as something you need to do. I mean, it's hard enough for me to figure out how to get my eyeglasses prescription forwarded to the new glasses store. It's always something that seems an opaque part of the process. Wait, how do I get these records transferred? But I will say 1 in 10 women being called for additional screening. I mean, that's that's much higher than I would imagine most people think. I mean, again, we sort of imagine this is a test where, you go in and we can immediately tell you, if you have breast cancer or not, but instead it's a much wider net being cast. And if people aren't, especially if people aren't emotionally prepared for that, that can be really stressful if, like, oh no, I got the letter from the screening place.
Right. And I was surprised that I work in a clinic with a lot of very well-educated staff and medical assistants and nurses, and they told me they weren't aware that 1 out of 10 women are called back. And then when I started talking with them about the fact that, well, this is 1 out of 10 on a single exam, but if you start screening in your 40s or 50s, you're going to have 10, 20 mammograms over your lifetime. And sooner or later, your risk of having one of those callbacks is quite high. And when I studied this, we found that at least half of the women after a decade were called back for additional testing. So I think it helps women to know that this is just part of the screening process in the United States. The callback rate, the 1 out of 10 callback in the United States, is much higher than it is in other countries. Really? In other countries, Sweden and some of the European countries, they only call back 2 to 3%, whereas in the U.S. it's about 10%.
That's why do you think that is? Do you have any clue why that might be?
Janie and I are both shaking our heads. I think that we're afraid of missing things in the U.S. I think we really do care and we want to try. But some studies have shown that the actual cancer detection rate is about the same. And so if you're calling back more people, but your cancer detection rate's about the same, we're not getting that extra bang for the buck that we had hoped. Janie, why don't you add to this, because it's a really complicated topic.
Yeah, there are a lot of things that go into the recall rate. So the recall rate, right, the proportion of women that we ask to come back is also related to cancer detection rate, right? Because our true positives come out of the group of women who are asked to come back. So there are things that we know that contribute to it. So the number of mammograms each year the radiologist reads, the more you read per year, in general, the lower your callback rates are. They never go to zero, right? Because you want to detect cancers, but they are lower in people who are high volume, in people who are subspecialists, like I am, who have done additional voluntary training after radiology training. And also, if you have to take into account the screening intervals in Europe, they are screening longer. And so if a cancer is developing, sometimes it's larger and easier to see if you wait 2 years or 3 years instead of every year. And that sort of has to do with sort of some of how you prioritize, right? Do you want to reduce mortality from breast cancer? Do you want to reduce mortality from breast cancer and find cancers as soon as possible, which is sort of what we have said here in this country? And, you just have to think a little bit. And as Joann mentions as well, we live in a different society about what it means to find a cancer or not find a cancer on a mammogram. So it really is very complicated.
Right. That's really interesting, because now you're sort of taking it, for me, from the level of, the decision that one woman might make to go to mammogram and what she might experience, to the sort of more public health side, where you say we're doing mammograms on such and such a scale, this many people are getting called back, and what are our goals of this type of procedure? On the one hand, it's really interesting. It depends on what you prioritize, right? Because if you prioritize, as you say, reducing the amount of breast cancer mortality above all else, there could be knock-on effects of that in terms of how you structure the program. Mm-hmm. I mean, there's also the idea, now that we're talking about it, where ideally it seems like you would want the callback rate to be as close as possible to the actual rate of breast cancer, right? So that you're not giving so many women false positives, because those have their own effects.
Mm-hmm. One thing that's really interesting, too, in terms of metrics is, do you want to save lives, like the number of lives you want to save, or do you want to extend life by years? So if you want to say, I want to save the greatest number of lives, then you'll really focus your screening on older women who have more cancer. Age is definitely a risk factor for cancer. But if you want to maximize the number of years, well, then actually you do want to include younger women, because when you find a cancer in a younger woman, she lives for much longer. So it's very complicated in a lot of ways, because really what we want to do is both. And so it's, how do you find that right balance?
Well, I'm here talking to Joann Elmore and Dr. Janie Lee. We will be back in just a moment, so please stick around.
Mugs, shirts, stickers, patches, tanks, and more are yours for the purchasing at MaxFunStore.com. Hey, you already love the podcasts, so why not take this to the next level and outfit your home and bod with our merch? MaxFunStore.com. Because if you have to wear a shirt, it should be one of ours.
Well, welcome back to Adam Ruins Everything, the podcast. I'm here talking to University of Washington doctors and professors Joann Elmore and Janie Lee. Well, let's keep going down the rabbit hole of the different results, that can come out of screening mammograms. So we also talked on the show about overdiagnosis. Could you sort of explain that issue to us?
Well, we should, I think, start by describing how cancer is diagnosed, because a few people watched the TV show and thought that we were saying that mammograms diagnose breast cancer, but mammograms are images and they diagnose abnormal areas on the images, and then that leads us to get more tests. And in order to diagnose breast cancer, we actually have to get tissue. You have to stick a needle in or get a little lump of tissue. And then that tissue is put on a glass slide, and another type of doctor, a pathology doctor, will interpret it under a microscope. And that's how cancer is diagnosed.
I see. And so overdiagnosis is that the phenomenon of someone being diagnosed with cancer when they don't actually have it, or can you break that down for me?
Okay, great question. The word overdiagnosis, that's a tough word. And I don't know if Janie and I like that word and feel that it actually works. And I actually thought you did a great job in the TV segment describing the topic. Basically, there are some women who are truly diagnosed with invasive breast cancer and with this thing called ductal carcinoma in situ. So they truly have breast cancer or in situ breast cancer, but yet it would never hurt them in their lifetime. And that is kind of hard to fathom. And I have to admit, when I went to med school years ago, nobody was even talking about this thing of overdiagnosis. And they've done studies, for example, women that die in car wrecks, and they cut through the breasts of these women that were healthy that died in a car accident. And they find invasive breast cancer in these women who died that didn't know they had it. So, many women walking around healthy may have breast cancer. We don't know what causes that breast cancer to kind of flip a switch and to become aggressive and to start causing bad things. So the word overdiagnosis, the women, they truly have the cancer. The problem is we can't look the woman in the eye and say, you've got the kind of breast cancer that's never going to hurt you and you're probably going to die of heart disease in 5 years. And because of that, I think it's totally understandable that women want treatment and that the healthcare teams recommend treatment. We can get into some of the subtleties of once you do have the tissue, we can get clues as to the aggressiveness of the tissue. Mm-hmm. But these women, they truly do have breast cancer. We know that there is overdiagnosis from many different types of scientific studies. We don't know what percentage it is. Some people say it's only 2 to 3% of all the women with breast cancer are overdiagnosed. Other people are saying it's 30%, 50%.
Wow.
Yeah, it's, to even back up and give a little more context, when we talk about the potential harms of screening, they are related to both false positives, which is when you have a biopsy and they tell you in the end it really was a false alarm. It's a smoke alarm sort of in your house that's in your healthcare system, that you didn't have cancer in the end. And then there's overdiagnosis, which Joann has described very well. And so this is another one of these complex issues that is related to patient and woman characteristics, where a false positive is more likely in younger women because age is a risk factor for breast cancer. And overdiagnosis is something that is more frequent in older women, in part because, as Joann says, the risk of dying of something else before this early cancer or slow-growing cancer could actually cause a breast cancer death is higher. And so it's a big issue. One thing I did want to say was that there are things that we're doing to try and minimize overtreatment, and I think that's also really important for women to know. One of the things we're doing is we're trying to figure out if we can provide less aggressive treatment. So one of the tests that I use, a breast imaging radiologist, is MRI. And there's a really exciting trial that looked at if you had ductal carcinoma in situ, which is a non-invasive cancer that is solely localized within the breast. It hasn't invaded. It's not thought to have potential to spread elsewhere in the body. Right now it's treated with both surgery and radiation. And this trial looked at women with DCIS and said, well, let's get a mammogram. And if it looks like there's not a sign that there's additional invasive disease, it's really localized, these women were randomized to receive radiation or not receive radiation because the outcomes are so good. Could we take our standard treatment and pull it back a little bit? So that's a really exciting trial where we're using something like imaging to help us predict how someone will do in the future and do less aggressive treatment. So it's going to take a couple of years for those results to come out, but I think it's really important that we're trying to study it and trying to minimize the harms of treating someone who might not benefit from that treatment.
Right. We sort of have this idea that, hey, it's so important to catch cancer early, and if you've gotten something that you're told is cancer on a test, then you should treat that as aggressively as possible because that's the best way you have to prolong your life. But it sounds like what we're learning is that sometimes when you receive that cancer diagnosis, that is a type of cancer that you actually wouldn't want to treat that aggressively because it might be very slow growing, and since those treatments can reduce your quality of life to some degree, especially if they're aggressive, you could end up in this situation where you're treating a cancer more aggressively than you should. And that knowledge is something that we now need to go in having when we get these tests, that hey, this diagnosis of cancer, it could be this more relatively harmless or less harmful type. Is that correct?
That's correct. And I want to put this in the perspective of the poor women who then get that diagnosis.
Right.
If you're the woman and you get the screening and you have an abnormality, you get a biopsy of the tissue, and then they tell you you have invasive breast cancer, we really can't give them complete assurance that they were one of those overdiagnosed cancers and it would never hurt them. And I think that puts women in a real hard position. As Janie described, We're studying this. We hoped that we can do a better job going forward. But I think it's understandable for women when you hear you have this. I have many patients who don't even have invasive breast cancer. They just have some abnormal cells, and they're so alarmed by it, they want to have a prophylactic mastectomy.
Absolutely. And I think it's because, women have a lot to live for, right? They have families, they have dreams, they have hopes and plans. And when you have a cancer diagnosis, you want to, you want to hit it, and you want to hit it hard because you want to do the other things that are important to you in your life. And so what I think is important to tell people about that is we are studying this, and we're studying it in a rigorous way with big trials so that we can really say this is a well-done study. We can trust the results. Another approach to minimizing over-treatment that follows over-diagnosis is the use of genetic profiling of cancers. So these are sort of new tests that have come out and are used to predict whether someone's risk of cancer is high or low. And sometimes there are these trials that are looking at women who might have been recommended for chemotherapy based on clinical characteristics. But if you look at their genetic profile, could we then reduce the number of women who would receive chemotherapy? So minimize the exposure to the harms, but still have good outcomes. And that's another very exciting area right now of use. And so, you might hear about something like an Oncotype DX test. That's one that's very common in the United States. That's what's used to help make those chemotherapy decisions. And I think it's a step in the right direction.
That's what is fascinating about this, is that it seems like the science is moving very, very quickly.
Well, we're trying. But sometimes technology doesn't always help. And let me give one example. Years ago, one of my clinic patients asked me, Dr. Elmore, why do I have to pay this extra $40 for this computer-aided detection thing on my screening mammogram? And I thought, that's a good question. This computer-aided detection thing is this computer program that they had developed, if you can teach a computer to play chess, you can teach a computer to help the radiologist. And so this computer-aided detection program was adding little arrows onto the images to help the radiologist so that they don't miss things. It was going to flag little abnormalities. And so we did studies of this, and we found that it actually wasn't helping like we had hoped, and that it was, every single exam had like an average of 4 little arrows on it. And so it was leading to increased callbacks, increased false positives. And candidly, it might have even been falsely reassuring the radiologist. And so from my clinic patient's question, I studied this. And so I think that we have hopes of technology. We have technophilia in our society, and that we think technology is always wonderful, but we do have to be careful. But I say this as an example of sort of technology that hasn't been as helpful. But let me ask Janie to follow up, because they're trying to reduce the false positive, and they now have these new fancy machines called 3D tomo.
We do 3D tomosynthesis. To follow up on the computer-aided detection topic that you raised, I think I want people to be hopeful about science and the scientific process. There was this hope that we had talked a little bit about some of the variables that go into a high recall rate, and what can we do to reduce it, and can we use computer-aided detection to help someone who hasn't had the subspecialized training or is a lower volume reader, kind of read at the subspecialist level. And so there was great hope for this, and then it turned out not to be as great as we thought it would be. But we know that because it was studied, and it was studied rigorously. And so I'm hopeful in the process and in the kind of persistence of the process. And when we turn our attention to tomosynthesis, I'm really excited about that. So tomosynthesis is also known as digital breast tomosynthesis, or 3D mammography. And it, like mammography, digital mammography uses X-rays to obtain an image. And it's also a refinement and an update in that the breast is a three-dimensional organ, and a standard mammogram takes a three-dimensional organ and projects it onto a two-dimensional plane. And what the tomosynthesis exam allows us to do, or tomo as we call it sometimes, lets us look within that volume of tissue at planes. And so sometimes when you take a three-dimensional organ and you project it onto a two-dimensional plane, you can have normal tissue that lies on top of each other and creates these shadows that makes us go, maybe that's something we ought to worry about. And with this new 3D technology, things that are out of plane are blurred and out of focus. And so we see things better in each plane. And so it helps us better find the cancers that are there, but not call back the possible abnormalities that are not really there. So it's very exciting technology.
And is that technology that is being used, or is this just still in testing and hasn't been rolled out to America's screening facilities yet?
It's being rolled out. It's being studied. Some women have to pay additional cost for it. And when it first was rolled out, in addition to women having to pay extra for it, there was additional radiation exposure with it. So with every new technology, we need to be careful. And I'm just appreciative of the radiologist and the scientist who are trying to help us reduce things like false positives.
Right. Well, it sounds like what it keeps coming back to is that we have great hope for all these technologies and processes to help us save lives, but we really need to look in a clear-eyed way at the overall benefits of these procedures. One of the things that there's a lot of different recommendations about mammograms. When we were writing our segment, we were, really looking at them very carefully and saying, well, there's so many different recommendations for when women get mammograms that we don't, it's hard to make a blanket statement about exactly what is recommended overall. But it seemed like the recommendations were overall changing, right, over the last few years. Is that correct? And if so, why is that?
It is correct. Years ago, they were recommending women start at age 35 with the baseline mammogram, and then age 40 every year. And over time, most organizations realize that breast cancer isn't as common as we had thought in the younger women, and the benefit is much more in older women, and I guess my definition of older changes with time, but, above the age of 50s, in the 50s and 60s, breast cancer is more common. So in general, most national groups are recommending starting later. And in general, they're recommending in the 40s that we start talking with women about this. And it's important to me that we let women make this decision. Some women, it's very important to them. They're nervous about it. They want to feel good and they want to take sort of action. And it's important for them to start in the 40s. Others want to start in the 50s. I have some patients that don't want to have mammograms at all. And it's important to me that we let women choose. And the one thing I have noticed is that all of these recommendations are increasingly adding this little sentence about informed decision making is important. But that's putting a lot of burden on the women to understand a very complicated topic that I'm an internist, and so I spend time with women in clinic, and I'm taking care of their hypertension and diabetes and other things. And candidly, we are not always as prepared and available to help them navigate all this information.
Right. And one thing I would add is that all these guideline societies are essentially looking at the same body of evidence, and they're coming up with slightly variable guidelines. And it's possible. I think it just shows us that reasonable people can come to slightly different conclusions looking at the same available data. I do want to highlight, though, the area of consensus, because I think that's really important for our listeners and for women who are thinking about breast cancer screening. Is the area of consensus is for women who are between the ages of 50 to 74. Everyone's in agreement that they should have a screening mammogram, at least every 2 years. And then sort of, that's where the variation starts to happen, is that, should you start earlier? Should you have your screening mammogram every 1 year, every 2 years? Should you have it after 74? These are things for women to talk to their doctors about. But that's sort of the clear area where everyone is in support. And finally, just to add that these are recommendations for women who are at routine risk of breast cancer. So if you have breast cancer risk factors, this may or may not apply to you. And this is another area to talk with your doctor about in terms of what is the best screening decision for an individual woman.
So they're all in consensus that that older women can be of great benefit, but it sounds like the recommendations have changed for younger women because we're learning more about the risks that come along with false positives, overdiagnosis, and those issues. Am I understanding that correctly?
Yes.
But one thing that we spoke about, Joann, on set that I think we touched on this in the episode, but I would love to hear you talk about it in more detail. I think that, everyone's heard, certainly I've heard since I've grown up, that, hey, you want to catch cancer very early and that's your best chance to stop it. But what you've told me is that our advances in treating cancer have become so much better that we're now having more success treating it even when it's not caught early. Is that correct?
I think that's a fair statement in that there really have been improvements in our treatment. Our treatment for breast cancer used to be really devastating and tough. They would remove quite a bit of tissue. And now they have phenomenal treatments, surgical, chemotherapy, and women are doing very well. Janie, what would you add to this?
I would say that it's due to both, and that it's been studied. There's sort of evidence for this. What's really interesting is that over a decade ago, the National Cancer Institute said, we're observing a reduction in breast cancer deaths, and what do we think that's related to? And so they actually, because you can't have this sort of counterfactual alternate reality where we go back and we have each woman go through two parallel lives, what they actually commissioned was a group of researchers to do computer simulations. And they said, we're going to give multiple groups the same data of inputs, create your models and see what the models say. But what the starting point was that the models had to recreate observable reality. They had to sort of model what we see is the decline in breast cancer deaths over time. And then once they had done that, they said, okay, now let's turn off screening and see what would have been the projection. Let's turn off treatment and see what would be the projections. Let's turn off both of them. And and I know sometimes you read the results of a study and you go, that was kind of obvious, but the answer actually was it's both. It's actually due to both screening and treatment to get to the observed reduction in breast cancer deaths that we're seeing, that we are both finding them earlier and treating them better.
That's wonderful. I'd like to talk a little bit about the cost of these procedures, because obviously healthcare, how expensive it is, how to pay for it is such a big issue in America today. But we've talked a lot about the sort of health risks of overtreatment, et cetera. But my understanding is there's a huge cost component of that as well. Is there?
Well, I guess I am pleased that insurance coverages, Medicare, that they mandate that screening mammography, if a woman wants it, it should be covered. But I know that if women go to different facilities, they can have different charges, and there's some very fancy facilities that may add charges to it. Cost is something that we're slowly paying more attention to in healthcare, and I've seen estimates that we are probably spending every year about $4 billion, and that's with a B, $4 billion, just on the false positives and overdiagnosis. That
Really?
has nothing to do with the screening exams and sort of the saving of lives. And remember that I should come back to the fact that there is a benefit to screening mammography because we keep talking about all the potential harms. But, that there is a potential benefit to screening mammography. We hope that the screening is detecting some early cancers and helping to lead to sort of easier treatment and saving a few lives. But there is a cost. And indeed, these estimates of how much we're spending on all these false positive tests, that is a lot. And when you have a mammogram, a screening mammogram, and if 1 out of 10 is detecting an abnormality, that's a lot of women coming back for additional X-ray tests. And sometimes it's just a simple one-view diagnostic mammogram. Sometimes it's an ultrasound. But these things add up. And in fact, the one thing that worries me about some of these podcasts is that the listeners may think, goodness, there's all these negative things I'm hearing them talk about screening mammograms. Maybe I ought to just be getting an MRI scan, one of these fancy MRI scans of my breast. And those cost thousands and thousands of dollars just for one. And so there are reasons that we are not pushing women to have other types of tests that have never been studied in the average risk population and that require intravenous contrast and all kinds of other things.
Wow. I wonder if... And look, this is a sensitive question because look, on our show, on our podcast, one of the themes we come back to is someone pushed for this or that thing to become a standard part of American culture because it benefited them. The classic, our original pieces that the diamond industry pushed for engagement rings, right? And I know that in the healthcare industry, there's there are often financial pressures at work, but it's much more complicated because you also have professional and honest, doctors who are involved in that process as well. But I did want to ask, in your view, is there any group or is there any overall maybe diffuse financial pressure that causes us to rely on these tests too much? Is that any component of it?
Well, let me start. The answer to that. First of all, studies have shown that these guideline groups, they are more likely to recommend a medical test if the members of the guideline committee benefit financially. They have studies have shown that. And there are some groups, such as the U.S. Preventive Services Task Force, that their members are not conflicted. They make certain that they are screened very carefully and they do not have these financial ties. In addition, in the United States, our healthcare system is pretty complicated, and we also have this one issue of medical malpractice. And for many years, the number one cause of a medical malpractice allegation has been failure to detect cancer. And so breast cancer is one of those big ticket items. So I think it's a great question. It's complicated. I don't think there's an easy answer. And at this point, I'm going to turf things over to our radiologist and ask Janie, what is your answer to that question?
Passing the buck.
Thank you. I'm so glad to have the opportunity to address this because I think there is, there is a perception that as radiologists we are paid every time someone comes in for a mammogram, and so therefore we are, looked at as biased in terms of supporting it. And I would say this is sort of an example of how having me and Joann here together is really important, because I would say that it's not about making, an extra dollar on the margin. It's sort of knowing that we have this tool that is fast, non-invasive, relatively inexpensive, although it adds up over time, that has been shown to save lives. And we want to use it. We want to help women live the lives they want to have and be healthy and live a long time. And so when it seems like there are efforts to reduce access to it, there can be outcry about it. So I think it's more, we believe in what we do. If there's any kind of bias, it's because we believe in what we do. I would disagree a little bit with Joann about the United States Preventative Task Force not having radiologists because they might be so biased in favor of it, because I feel like by excluding a certain perspective, you don't get to hear it. I would love to see someone, I would love to see experts, regardless of their field, sort of be able to weigh in on the specific topics. So I would love to see that change over time. And like I said, I'm hopeful in the process. So, maybe not this round, but maybe the next round. And to get back to our discussion about just costs in general, when you look at sort of in the United States, what we spend on healthcare, and then you look at what we get in terms of health, we frankly don't get as much as some of our peer countries in Europe and Asia and around the world. And that we really have to think about that, right? Because why is that? Is it because we don't have advanced technology? No. Is it because we don't have advanced knowledge? Well, no, right? You look at the trials that are being conducted. I think it has to do with, how are we deciding to use the healthcare resources that we have? And that's part of why we're having this whole discussion in the first place, right? Is, can we use this test that we believe in and we know that works? Can we use it better? And how do we do that? And how do we partner with that, with each other, and with the women who we care for?
Right. That's what makes healthcare so difficult. In our episode on the hospital, we didn't we didn't make an attempt to describe exactly why healthcare is so expensive in America. Because there are so many inputs to the system, there's how it's paid for. There's there's possible overtesting. There's the idea that you raise about malpractice being an issue that in order to avoid a cost associated with being sued for malpractice, they might order additional tests, etc. There's so many good and bad reasons that go into why it's so expensive and why our outcomes aren't better. We tried to focus on okay, we'll tell the story of the charge master, etc. But it's I guess I don't know what I'm leading to there. Just that it's incredibly complicated.
You're pointing out the obvious, but it's so important, and it is scary how much healthcare costs. We're talking about screening mammograms, but I was out of town recently, and one of my patients called up, and she had a breast lump, and so she came into clinic, and they didn't know her as well as I do, and they jumped to get all kinds of extra testing, a diagnostic mammogram, she got a biopsy, she had the pathology, she had the visit with the surgeon, and it was not breast cancer, but her bill was around $10,000. And this is a woman that is working 2 jobs. She doesn't have medical insurance. And so we do need to be cognizant, and we need to be careful.
So I'd like to, speaking of a patient coming in, I'd love to sort of close with this because we've talked a lot about, looking at how successful mammograms are from a sort of bird's eye view and, what these major recommendations are, for what whole populations of women at certain ages should do, etc. I'd like to know, Joanna, what do you when a woman comes into your office and is worried about breast cancer and says, okay, you say I should do what's right for me. How do I figure out what's right for me? What do you what do you tell her? If you can give a little bit of that sort of overall advice to our podcast audience.
All right. Well, let me start by saying a lot of women come in asking me, shouldn't I be performing a breast self-exam? And we haven't even talked about that. The whole conversation's been about mammograms and x-rays. But years ago, we used to tell women every single month, around the same time each month, examine your breast, palpate them. And I had a lot of patients that would feel guilty if they weren't doing that. And they also would try to do an exam, and they'd feel a lot of lumps and bumps and get really anxious and come in. And they have since studied breast self-exam, and the scientific evidence now is against recommending breast self-exam.
Really?
But I want to add that, I'm happy that I'm not making women feel guilty, for not doing it. But I actually think it's important for women to understand the contour of their own bodies and their breast, because a lot of the breast cancers in the U.S. are still detected by women themselves, not by screening mammograms. And so I want a woman to kind of have a general sense that, gee, there's this rock hard lump. So I have a lot of patients that ask me about breast self-exam, and I'll do a little bit of education about that to start with.
So you'd say don't put yourself on a regimen. Don't worry that you have to be doing it very strongly exactly once a month, but be aware if there are changes in your body, and sort of touch yourself regularly, if I can.
No, don't feel the need to touch yourself regularly unless you really want to.
Okay.
But it's hard, because years ago, every time a woman bought a pair of nylons, it came with instructions in big, bold font with big picture of a woman palpating her own breasts. And
wow.
Every time you'd go to the health club, in the shower stalls, they had these things hanging up telling the women, you need to examine your breast. And there was a lot of anxiety, and they have done a couple of large randomized clinical studies. They had a big one in China, and they found that it wasn't saving lives like we had wanted. It was leading to more false positives. But I do think it's helpful for women to get a sense of what's normal and what's not normal. I sometimes, if they are worried about breast cancer, I'll do a little bit of education. Things like I have them take their index finger, touch the tip of their nose, and then touch the bridge of their nose. And the tip of your nose is real spongy, and the bridge is kind of rock hard. And I try to get them to get a sense of what different parts of the breast and what suspicious things that might be much harder would feel like.
Got it. Okay. And then beyond that, what advice do you give about mammograms and about breast cancer in general?
Okay. Then women sometimes come to me and say, well, aren't you going to do a breast exam as a doctor? And we used to recommend that. And we found that it really hasn't been as well studied as mammograms. They're not as accurate. And in fact, the few studies of this is clinicians and well-trained nurses doing the breast exams, in order for them to be really good quality, the doctor had to palpate and examine a single breast for probably 5 to 10 minutes. And that's each, that's each breast. So you can imagine that patients would wonder what I was doing if I spent 5 to 10 minutes per breast. So we no longer have national guidelines recommending that the clinicians perform breast exams on our patients. If a patient comes in with a lump or a concern, then we do an exam. And some patients have wondered why we're stopping doing those breast exams. And it's because the quality wasn't as good, and there was no data showing that it was saving lives.
Got it. Wow, that's really startling to me. Cool. And then what next?
Well, now we're on to mammography, and I just want women to educate themselves and to decide for themselves how they want to engage with screening mammography. And the key is that there's no wrong choice. I just want women to be informed. There is a benefit. The benefit is more and I won't use the word older age group. I'm going to say in the 50s and 60s, and that I want women to make a decision that's right for them.
And what I would add to that is to talk with your doctors, your doctors like Joann, and come up with a plan that works for you. And once you start it, whenever you choose to do so, come back regularly. Health is unfortunately one of those things where you can't just do it once. You can't just take a pill. You can't exercise just once and be healthy. You can't eat a salad just once. And mammography is like that too. You can't just have one negative mammogram and say, okay, I'm cancer-free forever. It works when you come back regularly. So figure out, a plan that's going to work for you, and then come back regularly, because that's how it works best.
Well, let me ask this. That's wonderful advice. But if I could drill down a little more, when you say someone should figure out, a plan that works for them or decide what's right for them, well, we've talked a lot about I think we've done a good job of the information part about how, okay, there are these risks of false positives and overdiagnoses. On the other hand, mammograms can't save lives. How do you recommend people go about thinking about how to weigh those costs and benefits? Yeah.
Well, everybody has different values, and maybe it's one reason why I love the practice of medicine and I love being a doctor, because every patient is different. And what's important to one patient may be different to a second one. There may be some patients that have a family history of breast cancer, or they may be really anxious because their best friend was just diagnosed with breast cancer. They may be aware of false positives, but say, that would not bother me. I know totally about it. You've educated me. I want to do everything. And so it is hard how to help all of our patients make decisions that are right for them. And I actually have to say that, sadly, we doctors, I wish we could do a better job. I really appreciate your covering mammography and breast cancer screening in your TV show and this podcast, because just like Khan Academy is flipping education and getting students educated outside of the classroom, I want my patients to come to clinic with a little bit more knowledge. But there's also a lot of bad information out there as well. And so I appreciate your being evidence-based and trying to be balanced.
Thank you. Well, I'm, that's all that we can hope to do. So I appreciate that. I do love that you talk about values, though, because when I spoke with on a few podcasts back, Bud Hammis from who's covers end of life care and helps people make decisions about what the best thing is to do at the end of towards the end of their lives. What he really wonderfully brings to the discussion is this idea of values of thinking about, okay, what's important to me, what will be important to me at that time of my life, how do I sort of, want that, part of the story of my life to go. And I feel like that's something that we often forget to do when we're making medical decisions, that we think only about sort of trying to make the right decision or optimize the outcome from a, clinical perspective. And we sometimes forget to have that discussion about what's important to me. Is it more important to me to have known I've done every possible thing, or is it more important to me to maybe forego the discomfort of a treatment, or et cetera? I don't know. I really appreciated you saying that.
Why, thank you. And what one patient values, other patients may not, and it may be the opposite of what the doctor values, and what a patient values may change over time.
Yeah, I would agree with that too.
Right.
I think, really what business are we in? Are we in the business of imaging? Are we in the business of cancer detection? Really what it is we're about helping people live healthy lives, and what that means to each person is different. And so it is kind of a messy conversation, and I wish we could give you 3 questions that you could take home and talk to your doctor about, but it really is sort of what's important to you and how can we as your doctors help you get there.
Right. Well, I think that's a wonderful note to end on, unless you either of you have anything else that you'd like to add to the discussion.
No, but thank you again for covering. This is a challenging topic, and we appreciate your attention to detail.
Yes, thank you.
Well, let me thank Joann and Jamie one more time for coming on the show, and thank you to you folks for listening. That was it for Adam Ruins Everything, the podcast. We will be back in 2 weeks, so please tune in then. Our producer is Shara Morris, and if you like the show, please be sure to tell a friend about the podcast and subscribe to us on iTunes or your favorite podcast app. I don't care what podcast app you use, but subscribe to us on it if you like this. And don't forget to leave us a rating or comment wherever you subscribe. Again, Adam Ruins Everything is back every Tuesday night on True TV at 10 p.m. Eastern, 9 p.m. Central. You can find clips and full episodes at truetv.com/Adam Ruins Everything. And don't you guys say it with me, the Watch True TV app. Oh, you can find it on the app stores, wherever your apps are sold. Thank you guys so much, and we'll see you in 2 weeks. Bye-bye.
MaximumFun.org.
Comedy and culture.
Artist owned.
Listener supported.